Hi, and thank you for joining us. Welcome back to the American Society of the University of Haifa's weekly coverage on COVID-19 with Dr. Manfred Green, Director of the University of Haifa's International Master's Program in Public Health and Global Health Leadership. Over the past few weeks, Dr. Green has been sharing his insights into the ongoing public health crisis we face here in Israel, the US, and across the globe. For more information on the university's briefings around the coronavirus and time, please find a link included in this post. Thank you, and over to you, Dr. Green.
Thanks, good afternoon. Thanks very much, James. And I'm pleased to be with you all today. I'll give an update. I'm going to speak about vaccines today, but just let's very quickly give a quick count that we've gone over 4 million reported cases, which is an increase of about 14%, and about 280,000 reported deaths, which has increased by about 12%. What I'm going to talk about today is really the whole question of the vaccine. And in order to introduce it, I'll actually talk a little bit about what kind of vaccines we generally have, and then focus on the vaccines that are being developed and hopefully will be successful for COVID-19. So there are a number of types of viral vaccines, and I'm sure most of you are familiar with many of these, but let's just go through them quickly. There's what we call an inactivated vaccine, which is basically taking the virus, killing the virus using something like formalin, and then actually injecting the inactivated virus. And your body will recognize it, your immune system will recognize it as an antigen, and you'll produce antibodies. And it's relatively successful for some, maybe a little bit less for others. For influenza, we use that for the seasonal one. There is also another form. And it has a limited efficacy, but it's pretty good. The hepatitis A vaccines and the inactivated polio vaccines are both inactivated vaccines and very effective vaccines. In other words, they produce a very good antibody response. Then we have the live attenuated vaccines like the measles, mumps, rubella, and varicella, and also there is a live attenuated influenza. And these are vaccines made from the virus, which is actually weakened. I think we spoke about it before, and actually you put the virus through a number of passages and you weaken basically the virus until it doesn't really cause disease, or it causes very mild symptoms, and you use that as the vaccine. And the measles, mumps, rubella, and varicella vaccines are actually very good. One problem is that we usually have to give several doses. The immunity is not necessarily lifelong, but it is long-lasting. And if you give several doses, it's very effective. So in children, we give 2 doses, usually at about 12 months, and then another one up to age 6 years. And the influenza, as you know, we give annually because there's often a change in the virus, and also because it doesn't tend to last that long. And then there's something called a recombinant vaccine, which the hepatitis B and HPV vaccines are. And those are vaccines that are basically taking the antigen and actually genetically producing it through something like yeast cells. So it's a kind of a system where you're getting some other organism to produce this vaccine for you, but it's only producing a single antigen. It doesn't cause disease, and it's a very effective vaccine. Also, generally, we need to give several doses. Then there are the others that are called the live reassortment vaccines, like the rotavirus. And that's another technology, still a live vaccine, but based on another technology where we actually introduce, or we change actually the virus in a sense, but it retains its antigens in the sense that your body will recognize it and produce antibodies. And then there are others in development. So what I'm saying is basically is that the vaccines that are currently in use are all in this almost all in this category. When we get now, let's just go quickly to what happens when we go through approval. I'll go through this quickly. The FDA in the United States and most countries, the Europeans and other countries, have the same kind of process. You usually approve a vaccine on the basis of safety and efficacy. In other words, it doesn't cause any serious side effects, and it works. And usually that goes through a series of trials, and you do an efficacy trial, which is a large trial in a lot of people, and that takes a long time. Most of the vaccines you saw have taken years to produce. The FDA now has agreed that under certain circumstances, particularly what we would call almost emergency situation, we can use, or they approve the animal efficacy rule. In other words, show that in an animal model, if you inject the vaccine in an animal, they will develop antibodies and they will respond to a challenge with a live virus. In other words, you give them the vaccine and then you challenge them with the actual virus to see whether they protect it. And then you do trials in healthy humans to examine the immune response, the dosage, and important adverse reactions. There is discussion now, and it has been done on a limited basis for other vaccines, to use actual human challenge studies. I won't go into that now. It sounds a little frightening, and it's not as frightening as it sounds. But basically, what will be done is once the vaccine has passed the so-called initial safety evaluations and the dosage, you give it to human subjects who are volunteers, healthy volunteers, and then you actually challenge them with the live virus. In other words, you give them the disease. This is usually done in a closed setting where they get very good health care and they are not just wandering around getting sick. Obviously, you need motivated volunteers, and I might add that now I've understood that in the United States and perhaps in other countries, there are already several thousand people who have actually volunteered to be in these studies, in other words, and they're usually young, healthy people who feel that even if they get the disease, they won't become very ill. So let's go to the next slide. So what are the questions you're going to ask about vaccine? So the first question will be which vaccine? And the second will be how safe is it? Then how effective? And then we're going to have some very interesting questions about who's going to get the vaccine and when. So let's just quickly look at the which vaccine. Well, the which vaccines that are being produced now, I'll go through some of them. There are many vaccines at the moment at the stages of development. There are many companies working on this and institutions. So the candidate vaccines, and I haven't given them all, but I'll give you an example of some of them. There are a couple of companies who are working on an inactivated vaccine, which is very similar to the one that I mentioned for hepatitis A or for inactivated polio vaccine. Just killing the virus and then injecting it as a killed virus. There's an inactivated plus an adjuvant. I won't go into that too much, but you know, that's adding an actual, either something like alum, which is basically a metal compound. It's in minute quantities, so it's much less than you would get exposed to normally. It actually causes the immune system to be more active. In other words, it helps the virus or the killed virus to generate an immune response. And then there are other methodologies or technologies which I haven't mentioned yet, which are really new technologies. They're not new from now, but they haven't really come to the market as vaccines mostly. There's the so-called non-replicating viral vector used for the Ebola vaccine. And what you do is you actually use another virus or another virus vaccine like adenovirus, and you actually use that as a vector to carry an antigen from the virus that you actually want to inject against. A little bit complicated, but it has been used for the Ebola vaccine with some success. Then there are other vaccines which are called DNA vaccines and RNA vaccines, and these are vaccines where you're basically using the genetic material of the virus or using the genetics to actually create this vaccine. And that's been done for Lassa fever, HIV, and Zika. And as you can see, we don't have these vaccines. In other words, they're in development. It's a research area, but it's not yet been successful in the sense that we don't have vaccines for these diseases. And then there's an RNA. The RNA one is one of the leading candidates now for the vaccine against COVID-19. And that's also a part of this new technology. And in a very simplistic manner, you can say that this is a way of injecting virtually an RNA, sort of the RNA of the virus, which helps your body to produce the antigen, and then you produce antibodies against that antigen. And I've totally simplified it in a way that I hope that the virologists who are listening to me will not be too upset by that very simplified explanation. But these are vaccines then, as I said, the newer ones, like the non-replicating viral vector is already been developed, and it may be a promising one. The DNA ones have not really come to market as a vaccine, and the RNA is really a very new technology. So how safe are they? And I'll go through that quickly. Well, this is one of the very big issues. If we're going to be using a new vaccine, and as I'm going to go back one slide. If you look at some of these vaccines, we've got a lot of experience on inactivated vaccines, and generally they're safe. There have been occasional situations where they have caused some problems and then they've not been put on the market, or they've been taken off. Not really very serious, but at least enough for them not to be something that we would want to use in the whole population. So we have to be ready for what we would call some surprises. And we have to make sure we don't put out a vaccine that has some problem. Then the one for Ebola vaccine has very limited usage, so we really can't tell you too much about the safety there in terms of giving it to large populations. And the DNA and RNA have basically not been given to large populations because they're in development. So we have very limited experience in terms of safety. In terms of the animal studies and so on, we will have information on safety. I'm talking about safety in humans. So how safe will be one of the questions that we're going to have to ask ourselves very carefully when we start using a new vaccine, particularly if we're going to give it to large populations. If you were telling me that you wanted a vaccine for a limited population of 10,000 people, 100,000 people, even 1 million people, you may be able to tolerate a certain amount of risk of safety there under very strict circumstances like in the Ebola epidemic. But if you're going to be starting to give it to millions, hundreds of millions, virtually the whole world, as you like, and that obviously requires a very, very, very strict safety margin. You don't want to really make mistakes with this one. So that's one of the reasons why we may have to go slowly with this vaccine. How effective? Well, we really will not know how effective it is until it's in the field, because it's going to be very difficult to do trials, as we mentioned, and the only information we will probably have is on animal studies and very limited challenge studies in humans. So it's going to take us a long time, and I'm not sure how long, and then of course we're going to decide whether in fact clinical trials will actually be carried out and where and how. So a clinical trial is usually in a very large population where you give half, let's say, the vaccine and half not, and you see whether the vaccine is protected. But that means, of course, that half will get it and half will not get it, or they'll get something else. So this creates all kinds of ethical issues which have to be dealt with in clinical trials. And then the last point the second last point that I want to address is for whom. Are we going to give these vaccines, new technologies to children? Well, there are two arguments. One is that children are not really seriously affected by COVID-19 by and large, although there are some cases that are serious, such as the Kawasaki disease and so on. So we're not talking about children not being affected at all, but they would be affected much less. So should they be vaccinated when in fact we may think there may be a very small risk associated with the vaccine, although the risk is probably virtually zero, because after safety testing and after we've given it to large populations, we'll know about that. On the other hand, we would like to vaccinate children because they may be spreading the virus. And in fact, that's one of the ways in which we stop the spread of virus is we vaccinate children. So we will have this dilemma as to who we give it to. The last point I want to make there is for elderly people. One of the problems is the people who really need it are the people who least effectively respond to vaccines. In other words, elderly people do not usually mount a good response to vaccines. And this is true for many vaccines, including the influenza vaccine, where we often double the dose to get them to get a better response. So in the sense, those that we want to vaccinate and protect will be the ones who will be in that sense more problematic. So the final slide that I'll give here, and this is obviously a question that's being asked frequently and people keep asking over and over again, when are we going to see these vaccines? Well, we could go back to the same issue, and I hope I've made it clear. We want to go quickly because we have a serious problem. On the other hand, one of the risks of going quickly in developing vaccines is that you may make a mistake. In other words, you may develop a vaccine, A, that may have some side effects that you don't detect early on. So we have to be very cautious in the way we do it, and I would not expect us to give it out to thousands or hundreds of millions of people before we start gradually putting it out to see what kind of response it has. And of course, we have really no idea until we start vaccinating whether it really will be effective and for how long, because it may be a vaccine that will have to be given repeatedly. And like the influenza vaccine, that only protects maybe about some 50% of the people in the elderly and sometimes less, although it does have an impact on mortality. So these are the questions that we're asking in order to produce the vaccine. Thanks very much.